again for the invitation. What about mitral regurgitation? Why it's important to speak about age-to-age mitral repair? First of all, because a lot of patients had this problem, and then the incidence of mitral regurgitation is very high, and only a small amount of patients are treated. And then high incidence, low rate of patients treated, very bad prognosis. When the patient is not treated, the mortality is more than 50%. And then high incidence, small patients treated, very bad prognosis. And then this is a very important topic for us, especially in patients with secondary mitral regurgitation, because we know that there is a problem for the ventricle, and then for the valve, and then for the ventricle until a complete and irreversible heart failure. Age-to-age repair is an old idea, is an idea of Ottavio Alfieri, was the first intervention, the first surgical intervention. Now we know that surgeons are very good in the repair of mitral, but also by transcatheter view we can use age-to-age repair. The first device was mitral clip, and now we use from more than 10 years. This is the first guidelines in 2012 that recommend the use of age-to-age repair with mitral clip, of course in patients not operable by surgeon. This is the last guideline, 2020. We can see that the recommendation is class 2A in primitive and also in secondary mitral regurgitation. And now we have also another device that is Pascal, and then we have two devices to perform age-to-age repair, mitral clip by Abbott and Pascal by Edwards. We have a lot of experience with mitral clip. We treat in these years more than 150,000 patients. Probably the success of the procedure was linked to the simply use by venous approach without problem of access in arterial. The 90% of patients is eligible. The procedure is in the beating heart, and then we can adjust the result, we can repeat the grasping. There is also no problem of contrast, and then we can submit to the intervention patients with renal failure. What about the results? This is the bad results of 2018 Congress, European Congress of Munich. No difference on mitral clip compared with medical treatment, good medical treatment. This is the French registry. In this time, the mitral clip was already dead, but after few months in Congress, TCT Congress in Washington, the results of COAPT was completely different. We can see the reduction in terms of hospitalization and for heart failure, and also the reduction of mortality with mitral clip compared with medical treatment. And in American casuistic, we can see that the rate of success was very high, and also the complication was very low, and also the long-term follow-up is a very good long-term follow-up. We can see at 5 years we have consistent results in terms of hospitalization for heart failure and also in terms of mortality. And there was a lot of crossover during this year, but we can see that the advantage of mitral clip is consistent. And then what about these two completely different results? French results very bad, and US results very good. And this is the explanation. This is a technical explanation, because French registry enrolled in a very small center in terms of volume, and we can see that the acute result is completely different. Very bad results in French, very good results in US when the patients were enrolled in high volume center, and also The characteristics of the patients were completely different, and this was very important for us, for the patient selection, because the French registry enrolled patients with very important dilatation of the ventricle and not important regurgitation. And the patients of US are patients with dominant mitral regurgitation and not completely dilated ventricle. And in this editorial by Milton Parker, it is clear the mitral FR patients are patients without beneficial effect because the ventricle is already broken. The patient, the co-opt patient, is a patient in which is dominant mitral regurgitation and the ventricle is not completely broken. Now we have also new generation of mitral clip, G4. We have 4 kind of mitral clip, and then we can have best results like in expand G4 trial. We can use also an alternative that is Pascal. This is the results presented at the last Congress in Washington. We can see also good results, but probably the most important results were presented in London at the European Congress are the result of Reshape HF2 trial. We can see that with mitral clip we have a very important reduction of primary endpoint also in patients with mid-regurgitation, and this is a summary. We can see a 36% reduction of primary endpoint, a 41% reduction in terms of recurrent heart failure. Also, during the European Congress were presented the data of Matteron study, mitral clip against cardiosurgery, and we can see the results, no difference in terms of efficacy and a significant advantage in terms of safety. And then now we can see that mitral clip and edge-to-edge repair is a good alternative to cardiac surgery. This is the casuistic in my hospital. We can see that we increased the use of mitral clip during the years. Now this is the center number 5 in Italy for the use of mitral clip. This is a simple example. These patients come from another hospital, from Rivoli Hospital, with refractory pulmonary edema, and after mitral clip implantation the patients was discharged without problem. And now we create a network, for example, with this hospital. Francesco Tomasini is here in this room, and now they started also to use mitral clip without cardiosurgery on site. And then my conclusion is that severe mitral regurgitation carries poor outcomes, especially secondary, but also primitive. Edge-to-edge repair is an alternative to cardiac surgery, of course, in very high-risk patients or inoperable patients, after, of course, optimization of medical therapy and electrical therapy. Thank you very much.